member Telemedicine Society of India, a member Task Force Committee of Ministry of Health, Government of India, President Tamil Nadu Telemedicine Society. He's also President of Telemedicine Society of India, member of the Pan-African E-Network project, and also member of the Science and Technology Government of India for Telemedicine. And he also received award and honor as the Best Doctor Award from MGR Medical University, Lifetime Achievement from Lion Clubs, and Cushing Award Neurosurgery from Chicago University, United States of America. And today, Prof. Selvakumar will speak to us on mentoring in neurosurgery and telemedicine, a dedication to Professor Tetsuo Kanno. May I call upon Professor Selvakumar to share his screen?
Thank you, Boon Seng Liu, for the nice introduction. I would like to share my slides, and just give me a permission to share the slide, please. Yes.
You may share now, Prof. Yes, thank you.
Yeah. Oh, yeah. Thank you. Thank you, everyone. Good evening. And I would like to first thank the organizers of the committee of the third memorial lecture of Professor Tetsuo Kanno, and their kind invitation given to me. And I feel it's a great privilege and honor to be part of this memorial lecture today. And my special thanks to Professor Yoko Kato, and my homage and respects to Professor Tetsuo Kanno. He has been a mentor for many of us for the past several decades. This is one of the photos of Professor Tetsuo Kanno giving a memorial lecture. And he has been a great architect of the modern neurosurgery. I am deviating slightly from my normal neurosurgical talk today because I think this is my best opportunity to talk about Professor Kanno, because I never had this opportunity, so that I could part my old memories, which was a turning point to me, learn from my mentor, Professor Tetsuo Kanno. In fact, for the last 10 years, the young neurosurgeons did not have so much of that, did not know about Professor Tetsuo Kanno. And my young postgraduates were keeping on asking me more about him. So I thought this is the best time to talk about Professor Tetsuo Kanno. The history is very important for the younger new generation to know how and what a mentor can do to encourage the young neurosurgeon to achieve the targets. I'm not too sure whether this could happen in the near future or see someone filling this gap for Professor Tetsuo Kanno. He has been a visionary, a philanthropist, a disciplined artistic person, par excellent teacher, golden hands during surgery, with a helping tendency and a great mentor for young neurosurgeons, and very charismatic. He was a visiting professor of several universities, emeritus professor of medical colleges, founder of the ACNS, director of Fujita Health University, recipient of many Lifetime Achievement Award, honorary president of WFNS, president of several important organizations. Many young neurosurgeons of the present generation are very keen to know about him, and they would like to know something about his life history. Hence, I thought this will be the best occasion to talk. And this was one of the last occasion when he visited Chennai about in 2018, and he was with us for a very long time. Knowing him personally for more than 40 years, from my neurosurgery training program during his first visit to Chennai, India, for a workshop, ICP monitoring in Government General Hospital in 1981, which he participated at the invitation of Professor P. Narendran, who was then HOD and also one of my mentors. And he was very grateful, and we are very grateful to him. And then after that, there was no going back on this relationship. And this is what you could see is Professor Kanno with Dr. Narendran, who brought him first time to India. And the other photo is Dr. Narendran and Dr. Kanno with the Chief Minister. The Chief Minister is a very important person of our state. A mentor is often a combination of advisor, guide, a role model. Therefore, it's best choice, and also he will show others the right way to succeed with good communicator. And this is what we have seen with Professor Tetsuo Kanno. And this you could see Professor Kanno bringing a very important person from Japan and introducing to our Chief Minister along with Professor Narendran. Professor Tetsuo Kanno became very close to us after he had treated our Chief Minister of Tamil Nadu, and he became so popular doctor by providing treatment, the management of intracranial bleeding for him. And later he became so close after his recovery. And this you could see, this is a state function where Professor Kanno was honored by the Chief Minister of Chennai. These words, which were written in Japanese, were really written by Professor Tetsuo Kanno. Professor Tetsuo Kanno was always given a red carpet welcome during his subsequent visit to Tamil Nadu after his treatment. And you could see that he's taking a state honor from the police. And that's so powerful he was within as a friendship with us. And you could see he's walking with garland and then after the Chief Minister walking. In many parts of Chennai, even today, we carry Professor Tetsuo Kanno's name in the roads, and colonies were named after him because of his popularity and because he saved the life of Dr. MGR. And MGR was such a popular figure and the highest, biggest politician in India. And Professor Kanno had treated him personally and made him become all right to continue his work. The first CT scan mission, which comes into India, was inaugurated by the Chief Minister. This was purely on the recommendation of Professor Tetsuo Kanno. That time we never had the CT scan in the 80s. It was Professor Kanno who recommended that CT scan is a life-saving diagnostic tool, and this he brought it into Chennai. It's all because of Professor Tetsuo Kanno. Professor Tetsuo Kanno visited several times Sri Ramachandra Medical Institution, where I am working. More than 8 times he has visited our hospital. He has inaugurated the department 30 years back. Since then, he has visited to conduct many conferences, live workshop, neurocamps, cadaveric workshop, live surgeries for the benefit of young neurosurgeons. This was the beginning of the inauguration time where Professor himself came all the way from Japan to inaugurate the department. Most of the senior neurosurgeons in India had the benefit of knowing him very fondly and was very closely associated with him as a mentor and as a friend. I don't think there's any senior neurosurgeon in India who have not visited Fujita Health University at his invitation. Showing you the pathway and taking you to the higher level is the concept of mentoring. And Professor has been a great mentor to many young neurosurgeons throughout the world, provided them with clinical material, journals, surgical books, facilities to continue the neurosurgical work and education in their country. This was of high cost. He was a great motivator for taking up the complex and difficult surgeries and giving them the confidence as a mentor. At the beginning of his career as a neurosurgeon, he was a very aggressive surgeon in removing tumors completely. And he said to us that it has led to a lot of deficit in patients. At a later stage of his life, he was so mature, he was very clear and understood where to stop the major surgical procedures, giving back some portion so that the patient do not suffer from the deficit by removing lesions completely from the area, which can produce severe deficit to the patient, showing his high maturity concern for patients. This was a great teaching to me at that time during my fellowship program. Learned a lot of things from him. How and what we learn from our mentor will be a change in our life, especially when we are young. And when this molding is not available, it becomes very difficult at a later stage of our life. So we need to choose the right mentor very early to mold our life. Many of us were gifted and benefited by getting the right mentor in our early stages, and I was one among them to be benefited by our professor. His mission was to help young neurosurgeons from different parts of the world for training their skills, who will return as masters to their countries with well-qualified skills to undertake neurosurgical skills. This was one of his main themes. He took up this challenge to become a mentor for young neurosurgeons who could not travel to be benefited to undergo fellowship training to any part of the world. He simplified the process by taking up to their doorstep the training program so they could accomplish their training in their own countries. He undertook this training program as a mentor in a phased manner so that there could be a continuity in the training program. And this was given to them as workshop, live surgeries, cadaveric dissection, hands-on training like neuroendoscope, etc. The important part of the training program as a mentor, he took the whole team of faculties along with him. Equipments, teaching material, which would cost skyrocketing for 2 or 3 days training program. This clearly proved that he could give them a complete training program, what could have been given in Japan. The countries which benefited were almost of many Asian countries like India, China, Sri Lanka, Indonesia, Pakistan, and some parts of Africa. In return, his only expectation was that the underdeveloped countries would be benefited to do much better work and provide quality service to the people of the country. I can still not forget his words. He always felt that Japan was still a developing country when I knew that Japan has already developed. And this was very shocking to me when he told me, when he compared this with USA always. Professor Tetsuo Kanno has attended many of the national and international and annual neurosurgical conference across India and presented very valuable scientific papers, orations, and as invited guest. He has attended various neuro conferences at the invitation of several institutions across India and also organized several workshops in many parts of India. And this was one of the earliest functions which Professor attended with Professor Yoko Kato in India, Chennai. This was a very challenging, the Indo-Japanese cadaveric workshop, which he organized, was a very challenging and very expensive workshop. I should say, he had brought 20 microscopes with special instruments from Singapore, Hong Kong, and Japan. The cadaveric heads were specially embalmed with distinct chemical for visualizing the vessels were flown from St. Louis, USA, with lots of difficulty since there were a lot of restrictions in bringing these cadavers into India or taking them back after the conference. You could see the cadaver, the live cadaver which he got from USA, which was the most difficult part. And Professor, you could see this next photo where he himself was demonstrating in the workshop. This cadaveric workshop, where 7 eminent neurosurgeons from Japan participated as faculty come demonstrators, apart from our own faculties, which was also included the fiber dissection, which was one of the first of its kind in India at that time. This cadaveric workshop was very expensive and which was completely taken up by Professor Tetsuo Kanno, including their travel expenses. And this was the place where all the workshop of the cadaveric took place in our hospital. And you could see all these Japanese and whoever had come with him were very busy engaging, teaching the students. It took 2 years to organize this cadaveric workshop. As a mentor, it was only possible by him and such a large cadaveric dissection to be executed from outside the country. I could see all these Japanese who had come all the way to India to be part of us. Professor Tetsuo Kanno was very busy neurosurgeon in his own hospital. He had a very busy schedules, and in spite of all these, he undertook several trips to various countries to do surgical demonstration to the young neurosurgeon. Each time, Professor Yoko Kato was always accompanied with Professor Tetsuo Kanno, and we are very grateful to Madam Professor Yoko Kato. And you could see this is one of the surgical procedures she undertook in our hospital to teach the young neurosurgeons. And there were so many students and doctors and the young neurosurgeon benefited from live surgical procedures. I used to wonder when I was young, what made Professor to do all this? Why should he take up such difficult task in coming all the way, going to different parts of the world, teaching the young neurosurgeon? Why? What was the reason behind this? I asked him one day on the same subject. He replied that when he was young, during the difficult times of the Second World War, the Japanese were passing through a very, very difficult period during their school and college days. Not much of help he could get, and he could pass through much of the very difficult time. And this was one of the factors which turned him to help and give support to the deserving people. And this was the commitment which he said he will follow till the end, and he achieved doing so. But this is something, a very, very unique character of Professor Tetsuo Kanno. It's a very touching words which he told us. I was the second person to go from India for fellowship training program in 1988. It was a very unique experience, and many things were new to me. On landing in Nagoya airport, Professor himself came and received me late night. This was a very unique quality of being a mentor, and took me for a dinner, made me comfortable before he could take me to my place of stay. I was very much eased. This was a high quality of Professor Tetsuo Kanno, which I can never forget in my life. And many others who went for a fellowship program also experienced this during their fellowship program. When the training program started, all the fellowship generally are given the priority in assisting in most of the cases. And Professor was kind enough to explain during the surgery the difficult steps to be approached, and also he guided us when we are doing surgical procedures. This was a great quality of being a mentor, which was also practiced by all his faculty members of his institution. Such a training program gives you the confident level and success of the fellowship training program. He was a very disciplined person. His schedules are very clearly followed. He will be the first person to enter the ICU in the early morning hours, and he makes sure that he gives the right instruction to all his faculties, and the secretarial staff will also attend compulsorily. This was followed on a day-to-day basis. As an administrator, he could manage many things because of his planning oversight. I have seen his calendar, which was scheduled for the next 2 years, and that was his life, which was going on for several years. He gave the facility of the video recording for all surgical procedures during the fellowship training program for the faculty who attended, which were very costly, but these recordings were very useful and benefited too many young neurosurgeons on their return. His administration capacity was par excellence and superior, which made his department to grow, and had an overall capacity to control every step of the faculties. He had respected all his colleagues and faculties in a very friendly manner and extracted the best help from them, and everyone were really to support him in whatever way which is possible. And this he could see all his faculty members with Professor Tetsuo Kanno at the Fujita Health University. He was very friendly with all his patients. He spent a lot of time to discuss with them on their issues, problem, which made him so popular among patients. I could see that when I was working with him and helping the outpatient department, the way he approached them and making them so comfortable. He used to organize excursions to the patients with family members, spending a lot of time with them, especially on the stroke patient, and this used to be one of the routines in their department. ACNS, Professor Tetsuo Kanno started this program, and this is a very important program to his heart for the young neurosurgeon. As a mentor, he took up this training program, and he was very close to his heart, where more than 100 neurosurgeons were selected in different parts of the world, especially from the Asian countries, and it was a 5 days international conference. Senior neurosurgeons on various subspecialties from various countries were invited as faculties to give lectures Boarding, air travel, and other expenses were completely taken up by the ACNS committee under the leadership of Professor Tetsuo Kanno. Many young neurosurgeons from India were benefited by this ACNS conference, and now they have all become a senior neurosurgeons in their own countries, working in a premier institution across the world. This conference was conducted once to 2 years, and is one of the most expensive conferences, and no other neurosurgeons have attempted to take up this challenge so far to train the young neurosurgeon. He also made sure the young neurosurgeons were given their stay in the best hotels at the free of cost. 30 years ago, he conducted the mega free medical camp at our hospital, where he screened 10,000 patients, and personally he had seen all the critically ill patients, and some of the patients underwent surgery through this camp in this hospital. This is one of the biggest camps ever conducted in the state of our country so far in the private institutions, and as concerned, you could see the professor himself seeing all the patients on his own personal note. I'm grateful to the entire team of faculty with Professor Tetsuo Kanno and the support from the Fujita Health University, like Hiroshi Sano sir, Professor Yoko Kato, Motai Shoda, Ishiyama, Imai, many others who have actually participated along with Professor Tetsuo Kanno, and their visit to India in giving full support to the welfare of the young neurosurgeons. This you could see Professor Sano and Professor Yoko Kato after their oration period. And this is one of the neurospine clinic which was opened up by Shoda. He came personally to give these lectures. Professor Kanno and telemedicine in India is a very important issue. I'm sure most of you would be surprised to why and what was the reason for getting Professor Tetsuo Kanno involved in telemedicine program in India. 2 decades ago, Professor Tetsuo Kanno introduced me to the concept of telemedicine by bringing in tele-education program through telemedicine in our country, by having the first Pan-Asian Neurosurgical International Conference connecting 4 countries, that is Singapore, Japan, Hong Kong, and India in the year 2001. That was the beginning of telemedicine. In fact, he is the one who brought in this concept of telemedicine to India. The concept of telemedicine was not clear in India till 2000. We never had the hardware or software. And I was thinking the conference was to be done through telephone. It was then Professor informed me there are special equipments which are required for doing the multi-point video conferencing, which was only, and Professor told me all this has to be done within 1 week. Thanks to the management who made it possible by importing the equipment from Hong Kong with customs clearance and getting the broadband facility into the hospital to make the program successful. And this conference was very successful, which is one of the first telemedicine conference in India in 2001. And then there was no turning back at all. And then subsequently, Professor interacted with several institutions in Chennai, Apollo and other institutions. All Professor was interacting through teleconferencing, and which is a very, very successful one later on. Professor Tetsuo Kanno was honored with citation by the Telemedicine Society of India in the year 2018 as a world-renowned neurosurgeon and honorary professor of neurosurgery of Fujita University for his rich contribution, and also who introduced the concept of telemedicine for teleeducation in India 2 decades ago. He was given the first honorary membership of Telemedicine Society of India. I'm very happy to say today that telemedicine has gone to the heights in India, both in teleconsultation, where lakhs of teleconsultations are being done by various premier institutions. And especially this has become more post-COVID with regards to teleeducation. The major medical institutions are interconnected for sharing CME programs every day at our hospital. About 4,000 CMEs have been conducted and telecast through highest, which is in our hospital, which is one of the highest in the country. All because of Professor Tetsuo Kanno was primarily involved with the concept of telemedicine in India. In the year 2018, we invited Professor Tetsuo Kanno, and this was his last visit to India. to felicitate him during our Silver Jubilee function of the Department of Neurosurgery and 2 decades of telemedicine. That is the time he was very clear, and that was his last visit to India, which was very upsetting to hear from him. But he said, this may be my last visit. But he actually participated and spoke quite extensively on the importance of training program for the young neurosurgeon in coming years. We only wish Professor was with us for some more time. That could have benefited more younger neurosurgeons, but unfortunately, we lost him. But I'm very happy to see this legacy is being carried on by his team, especially Professor Yoko Kato, who have been supporting the ACNS, Society of Minimally Invasive, WFNS, where a lot of education programs are being taken up on a regular basis through online, which have benefited hundreds of neurosurgeons, young neurosurgeons. Today, we are very thankful to the entire team who have been supporting this education program. And I'd like to thank each and every one of them for this. In this journey of Professor Tetsuo Kanno's vision, we are sure we can support this education program in coming years. I once again like to thank each and every one of you, Professor Liu and others, Dr. Balamurgan and others, for giving me this opportunity to talk about him. I thought this could be the best opportunity I ever had to talk about Professor Tetsuo Kanno. And thank you very much to all of you. Thank you.
Thank you, Professor Selva Kumar. Indeed, we did now know more regarding our Professor Tetsuo Kanno. May I call upon Professor Abhidasha to chair this session, Professor?
Thank you, Dr. Liu. Thank you, Professor Selva Kumar. That was a wonderful tribute to Professor Kanno. And it is just amazing to see how many good things he has done. When I was a young neurosurgeon, I was also one of the, in I think 2007 or 8, invited in one of his 100 selected candidates for ACNS in Nagoya, Japan. And that was the first time I met him. And believe me, he's a great and humble person. And thank you for all your comments. And we are very happy and proud that Professor Yoko Kato is continuing his legacy in continuing to educate young neurosurgeons all over the world. I would like to now invite Professor Tomasello for his comments.
Thank you so much. It is a great story. The story of an inspired neurosurgeon who was dedicated all his efforts to neurosurgery, and with a great reflection on the patient outcome at the end of his long life experience, and dedication to education. I think that he was a pioneer, and the speech of Professor Selva Kumar told us how he was involved in the telemedicine program, and this is anticipating what we have done with in the COVID time. So it's very important to have all together, also in these webinars as we are doing today. So I think that we need to have such inspired persons in neurosurgery. Professor Yoko Kato is really is following the legacy of Professor Tetsuo Kanno, and she is absolutely very much involved in education, in promoting meetings and enhancing the education of young neurosurgeons. We are indebted with these friends and colleagues, and I think that a mentor, a master as Tetsuo Kanno has driven a pathway that we can continue just to honor his memory.
Thank you, Professor Tomasello. I would like to now invite Professor Amar for his comments.
Thank you very much, I really had a lot of emotional feelings as I was listening to Dr. Sylvie Kumar. He really presented an excellent presentation of Professor Tetsuo Kanno. Professor Tetsuo Kanno is a phenomenon, really. He is really has his own legacy. I was lucky to see him when I was young, when I was in Japan. Then I had, after I moved from Japan, I started also to see him in conference, and he came. I'm sure that is all what we said, all of you know, how excellent surgeon he was, how dedicated teacher and educator he was, how humble person he was, but also, plus this, he was an inventor. He had many new ideas to invent a lot of things. He is a visionary. He had a vision for the future. He could see what is coming, and even he could make what the future better for the others, for the young neurosurgeon everywhere. He has also deep philosophy. He has always felt patient comes first, and everything comes for the patient, regardless what is the cost. Before anything, patient comes first. This is the word I heard from him one time when we talked. I was asking him, that is, what is the most important thing in his life? He said, patient comes first, and then anything else comes after that. He really has a philosophy, he has a mission, and he has a vision to work for and to achieve. And it was also great, equally great, to see Professor Yoko Kato following his steps. And actually, she was working with him not only as an assistant, but shoulder by shoulder. And as we see now, the legacy of Professor Yoko Kato is just that is the continuation or parallel to the legacy of Dr. Kanno. It is true, I heard that it's many young neurosurgeons call Professor Kato is Mama Teresa of neurosurgery. She is. She is the Mama Teresa of all neurosurgery, and she is a great. But this is also if you say this is thanks to Professor Kanno. It is one of his important talent to choose the good people who can work with him and work for. I think that is the legacy and memories and lessons of Professor Tetsuo Kanno will remain with us forever. And I think it is our task and our duty to keep this legacy, to extend his lessons and messages to all our young generation. Thank you very much.
Thank you, Professor Amar. Professor Kato, would you like to say something?
Very much, Mr. Selva. So just 20 years back, so almost just yesterday, so we had a very good time with Professor Kanno. And also you mentioned so many good things of Professor Kanno. But we all the department person know his true face. So but I think his life is almost 100% life of the patient. So I admire his the style, and also we all follow his the step now. Thank you very much, Selva. Wonderful talk. Thank you very much.
Thank you, Professor Kato. Dr. Liu, over to you back.
Thanks, Prof. Adibasha, for chairing this session. So we may move on now to our second session. May I call upon Professor Franco Silvada to invite our second speaker, Professor Hildo, for his lecture. Professor Franco Silvada is a full professor of neurosurgery from the Department of Neurosurgery, Humanitas Clinical and Research Center, IRCCS, Department of Biomedical Center, Humanitas University Milano, Italy. As every one of us know, he's the immediate past president of World Federation of Neurological Societies, and also past president of Italian Society of Neurosurgery. May I call upon Professor Franco Silvada? Professor.
Well, Can you hear me?
Yes.
Correct. Okay, so I'm very honored and happy to be with you this important day, and I have to thank the Asian Society and Professor Yoko Kato. We are long-standing friends for this invitation. I remember Professor Tetsuo in Nagoya. I was visiting Japan for the first time in my life in 2000 for taking part to the Nagoya meeting, and I was I don't say surprised, I say astonished by the fact that he invited 100 young neurosurgeons to an educational event. This it was complete. I've never seen anything similar in the year 2000. So I was surprised by the dedication of this professor from Japan to the education and the training of young neurosurgeons. In the same spirit, I'm going to present you Professor Hildo Acevedo, also a long-standing friend. We have been working together for many years in the World Federation of Neurosurgical Societies. Professor Hildo Acevedo is the Emeritus Professor of Neurological Surgery at the University of Pernambuco, Recife in Brazil. He has organized a huge number of events, also the interim meeting of the World Federation in 2011. And well, he has many honors to be remembered, but I remember only one, which is for me, when I was the president of the World Federation, the most important. He has educated with passion a large number of young neurosurgeons from Brazil, from South America, and also from Africa. Many neurosurgeons from Africa, even not Portuguese speaking, spend a large part of their education in Brazil, in Recife, with Professor Hildo. So I think we must recognize a lifelong dedication to the education and training of our young colleagues. So Hildo Acevedo has always had a very good interest in traumatic brain injury with a long-lasting experience, many papers. So I am very happy to introduce his presentation on decompressive craniectomy. Hildo, nice to see you again, and nice to see you all again.
Can you hear me?
Yes.
Can you see my slides?
Yeah, yeah.
Yeah. Oh, yeah. Good evening for you, friends in Asia. I think good morning for my friends Franco Tabardet, Tomasello in Italy. It's a great pleasure to be with you today. Franco, my friend, thank you very much for your kind words. It really did touch my heart. Don Franco Tomasello, it's very good to see you, my good friend. Keep my friendship, my work friendship. Professor Yoko Kato, I'm deeply touched for this invitation. I'm very honored for, and I express my gratitude to talk on a day when we pay tribute, we honor the legacy of Professor Tetsuo Kanno. I didn't meet Professor Tetsuo Kanno when I entered the AEC of the WFNS in 2005. I was a junior assistant secretary, and he was the second vice president for Asia. And he was always very kind, as has been expressed by the previous speaker. He was a friend of the young neurosurgeons. He always devoted a very good friendship for me. And as Franco has said, in 2007, during the WFNS interim meeting in Nagoya, he took, without any kind of expense, 247 young neurosurgeons to attend that meeting without covering every expenses from traveling to accommodation, etc., etc. So, Professor Tetsuo Kanno, what else can be said about Professor Tetsuo Kanno after what has been said by the previous speaker? But I would like to say that Professor Tetsuo Kanno, above all, he was a bridges builder. So he tried to make this small world even smaller, and that's what's one of the main legacies of Professor Tetsuo Kanno. Thank you very much. That's my hospital, where has been all my neurosurgical life has been in this hospital ever since I came back from England in late 70s. I'm going to talk today. I understand that this is a very controversial issue, and we are going to talk today about my impression, my views about this controversial issue, and what we think, what's our policy in our department after, for the last 8 or 10 years. We are going to share with you, and what I always say to my residents, my function is always to raise doubts, to compel the students and young medical doctors to have doubts, to be always skeptical, and to go to the books to study and complement this with clinical practice. You see, this has been our surgical performance over the years. Fortunately for the residents, we didn't decrease very much our number of surgery in 2020, 2021. So the teaching of the young neurosurgeons of the residents was not very much impaired. So we continue doing our conference, our rounds. So we made the best for our people, maintain the best clinical practice that I could afford and give during those tremendous and very sad times. Well, for the young neurosurgeon, we always know that raised intracranial pressure is a common cause of death and disability. It decreases the CPP, it increases the intracranial pressure, decreases the CBF and the PO2. And then we have severe TBI. We know that 65% of those people, they might have raised intracranial pressure. What do we do when we have a patient in the ICU with raised intracranial pressure? We raise the head for about 30 degrees. We give an adequate sedation, optimize the ventilation, hyperosmolar therapy, CSF drainage, hypothermia, and in the end, barbiturate coma. Barbiturate coma is a very also controversial issue, and also always I remember what my good friend of Franco, also good friend of my Graham Tisdale, told me once. It's a great poison. Tisdale told me it works, but it doesn't help. That I quote to Graham Tisdale many years ago. So DC is of course an effective way to reduce ICP. It might promote normalization of cerebrovascular reactivity, also reduction of glycerol and some incitatory neurotransmitters. Well, going back to the history, it's been done at the beginning of the last century by Korsha. And you remember that Korsha was the first surgeon to get the Nobel Prize in 1909 due to his work on the thyroid gland. And Dr. Cushing, perhaps after being in Switzerland at the beginning of the last century, also started to write about this issue. So in the 50s and 70s, we had a lot of publication, but there was no standard technique. There were reports of circumferential craniectomy. There were small craniotomies that it make things worse rather than improving. Wide variation of options, but so because of this, we DC, the compressed craniectomy, somehow faded away. So, but that's what we can see, very bad technical procedures. So that's one of herniation of the cerebral tissues, etc. So, but in the 80s and 90s, because of neuroimaging, because of the CT, we renewed the interest on the decompressed craniectomy, knowing that it reduced the ICP, but there was no randomized studies. So some publications said that they might lead to reduction mortality compared to medical management, but there was a call for randomized control treatment studies. So that's when we start thinking that RCTs should be necessary to shed some light on this difficult issue. Well, but at the beginning of this century, we start seeing that large and big craniectomies could be better and improve, reducing mortality and improve surgical results, bigger rather than small. So it was at the time already agreed that if you go for a DEC, you should do a very large one, going sharp on the temporal fossa and the drilling of the pterium, etc., rather than doing a small craniectomy. Also, we understood that, again, this paper from Cambridge, we understood that it decreased the intracranial pressure. But that's the $1 million question. DC effectively reduces the ICP. But does it turn to be an improvement for the patients? Does it bring better clinical results? So for this, we had to go, and the literature has got two randomized controlled trials. We have the DECRA study, and you have the rescue ICP, which Franco Servadei is one of the authors. So let's go quickly over them. So DC, it was the DECRA trial. It was from 2002 to 2010, 155 patients randomized, best clinical treatments, DC plus best clinical treatment. So a bilateral, that's one of the first and big issues, because a bilateral frontal craniectomy, there was no falx or sagittal sinus division. I have seen a patient operate in another department where this procedure was done without cutting the falx. So I could see the corpus callosum completely destroyed and cut by the brain, which was going up after the DC. So what DECRA, in the end, DECRA showed that it brought worse clinical results, and there was a greater risk for unfavorable outcome. So the death rate was similar in both groups, but I'd like to point out something that got out of this study, that the mean time from injury to surgery was 37.5 hours. So we had then the rescue ICP published in 2016. It was 480 patients randomized from 73 different countries, 73 different countries, 73 different institutions. It might raise some a bit of difficult to analyze the results, but anyway, what did you see with the rescue ICP? We saw that the mortality was decreased, but was an increase of disability. So many people were disappointed with this result. But I like to point out a few things. So the time from injury to randomization was more than 72 hours in more than 42% of the patients. Perhaps it's too much time for you to decide which kind of treatment you are going to lead or to take your patient. And also the mean time from stage 1, you remember that stage 1 was just taking patient to ICU, sedating, optimizing the ventilation, etc. No big deal in terms of clinical management of the raised intracranial pressure. Again, the mean time from injury to stage 1 was more than 12 hours in almost 40% of the patients. And the mean time from stage 1 to randomization was around 44 hours on both groups. For me, it's a long time for you to wait and to decide what you're going to do. So again, the mean time for randomization to DC, it was 7 hours. So this point that I bring to discussion is that 70% of the patients were treated in the UK, so 30% were treated somewhere else. The mean time was bigger than 72 hours from injury to randomization. It was found in 44% of the patients. Again, for me, too much time for you to decide which way you are going to lead your patient. The mean time from stage 1 to randomization was 43 hours. So you spent 53 hours with your patient on barbiturate therapy until you decide what if you control or not the intracranial pressure, or you are going to send the patient to crossover to DC. A very important point that I would like to raise at this moment is 73% were bifrontal craniectomy. So bifrontal craniectomy, or by all means, the patient who needs a bifrontal, by all means, is completely different for the patient who need unilateral craniectomy. So you cannot extrapolate the results for the that you have for patients who need a bifrontal craniectomy when you are going to analyze the patient who did have or did need a unilateral craniectomy. Remember that it was an intention to treat, and the crossover was 37%. Let's go to, so DECRA study, the mean time was 37 hours. The rescue study, mean time from injury to surgery, 56 hours. Crossover was from stage 3 to medical treatment was 37. So again, I think that was too much time before you decide whether or not you are going to do an operation on these patients. So that's what happened after the rescue ICP. Many people became disappointed and perhaps stopped doing the AC, but well, if you have a very severe subarachnoid hemorrhage, grade 5, for instance, would you hold the need for treatment? No, you do. You carry on. You do the best you can. So when you have patients with this kind of situation, you only achieve good results in 26% of your patients. Then why should we withhold treatment with the patients with severe TBI for doing stopping them to have a decompressed craniectomy? So you should use the same rule that you have for patients with severe subarachnoid hemorrhage. That's what we did over the last 80 years or so. We are mentioning about primary DC, so that was our protocol that we had. So we took the patients based on the Glasgow Coma scale and based on some radiological signs. So we didn't have too much time to take the patient to the ICU. Before surgery, we did not routinely monitor the ICP, neither performing any clinical treatment of intracranial hypertension, except the ATLS procedure and some osmotic therapy on the way to the OR. So that's what we did from 2015 to 2018. So we are working on the later results, but that the pandemic stopped us to analyzing the years 19 and 2020, and also to receive the patients in the outpatient, because outpatient had been practically closed during the pandemic. So we are working on this data. We are going to publish very soon. So we had 350 procedures. Remember that 84 patients were discarded because we didn't have enough necessary information. We did divide patients that we did the operation before 12 hours and after 12 hours. So what we had this less than 12 hours, before 12 hours. So there was no difference when you compare these points. So patient operated on before 12 hours and after 12 hours. We see that you operate on very much more patients on a worse neurological state, and this was statistically different. But the Glasgow outcome scale by the time the patient left the hospital was much the same, and there was no much different related to infection. So, but you see, you have very bad, you have the same outcome results. Never mind you operate on later or sooner, but if you perhaps doing this operation early, you could save some lives. And having very good results very good results. I won't say very good because 3, I can't say very good results. Perhaps we are going to split this between leaving behind the 3, analyze only 4 and 5. But so the results come to the rate of 50%. So again, when we go a bit earlier, again, we less than 6 hours, we did the operation statistically more on patient in coma or less, 8 or less. So the results were the same, but again, I would emphasize that if you wouldn't had operated these patients early, perhaps those patients could have worse results. Again, there was the issue of doing duroplasty or not doing duroplasty. You see that the patient where you operate on very early, we didn't do duroplasty because the patient were in a very bad shape, and we need to take them back straight to ICU. But not doing duroplasty, it did not reflect on more CSF leak or more infection. So that's what we think. I think that we're spending too much time doing clinical maneuvers to stop to decrease the intracranial pressure. Perhaps this delay might have an implication on the results that you could see on both studies. We think that there are some issues about the best surgical technique to perform the DC. So we did publish a paper that we did a prospective study whether or not the patient should have duroplasty. So we did this prospective study. We published that. You see that there was not doing duroplasty did not reflect on more wound infection, brain abscess, subgaleal, CSF leak, etc. And then also we did decrease the surgical time, and also we spent less money to our hospital. So again, this paper was again demonstrated that when you have a bigger number of patients, the absence of duroplasty did not reflect in more CSF leak or infection. So this has been also followed by some colleagues around the world. So you have Professor Schimdeck in Heidelberg, also my friend Volker Seifert in Frankfurt. So the absence of duroplasty is not, I think, coming out of the blue. how about the cranioplast? We had published how do we proceed with the cranioplasties, and so we had a study when we evaluated some symptoms and signs of the patient before and after the cranioplasty, and we saw that in many of these complaints, the patient get better after the cranioplasty. There are, of course, some morbidities. Fortunately, we didn't have, never, touch wood, never had any malignant cerebral edema after cranioplasty, as we have seen very often in the literature. That's is very cheap. We had a mold made on a 3D printer. So this mold is sterilized. We make the mold with methacrylate and we implant, and the surgical results are very good. So what we can say as final remarks, we can say that the patient operate on the first. The patient operated on the first 12 hours. They had the same function results, either operate on early, very early. The surgical results were the same. But again, we see that we say, I think, that as we operate on more patients in coma 8 or less, you see that with this procedure, operate on early, we could have saved lives. Otherwise, they might go to very much worse results. So again, I would like to emphasize that results are gauged by the hospital discharge, and we are going to publish the results after 6 months. Is an ongoing study that I think that we could save some lives if you do this procedure without increase the morbidity or having high morbidity than the pathology itself. Also, I think that DC without neuroplasty is safe. It does increase the CSF leak or infection, also decrease the surgical time, promotes a reduction in hospital costs, about $400 per patient on average. Thank you very much. Again, I thank Professor Yoko Kato and Professor Vade for this kind words. Thank you very much.
Thank you, Professor. Professor Franco, your comment, Prof.
Yeah. Hello. Thank you, Ildo, for a very comprehensive and important presentation. I think you have touched one very important point, and I have a question for you. The important point is, how do we extend randomized clinical study who are done in a limited part of the world? Usually in Western countries, you have seen that the DECRA study was done mainly Australia and Saudi Arabia. The rescue ICP study was done in UK, and if you add to UK, Italy, and Spain, you have 95% of cases included. Obviously, this is limiting the applicability of a study. I give you an example. We published that the result of decompression are better after 24 months. How many countries can treat their own patient for 24 months? So I think this is an issue that you have shown that must be taken with consideration. And as you have also shown, there is also the issue of timing. Both studies are late decompression. As you have shown, you may do earlier with better results. So I just ask you, and I see Ipe Cherian on the screen, so I ask both of you about, we now can control ICP with different techniques except decompression. We are not fighting about decompression, will still remain. But we have two new techniques. One technique is the so-called floating or hinge craniectomy, where, as you know, Ildo, there has been published in Brazil, as in many other countries, but one of the first publication was in Brazil. So I'm asking Ildo, what do you think about the hinge and floating craniotomy? And we have Ipe here. What also can be the role of cystanotomy in all these, let's say, surgical complex management of raised intracranial pressure?
Thank you, Franco. That's a very good question, because this technique has been described by a good friend of mine who works here in Pernambuco, is a member of the Pernambuco Academy of Medicine. And I've done in quite a few cases, I would say between seven, 8, or 9. But in all of them, I need to go over and to do a full DC. So I have a limited experience of 7 or 8 patients altogether, I think, but all of them because of raised intracranial pressure, because of deterioration of clinical signs, I had to go over and to take the bone out. I must tell you that I agree, but the only point, perhaps we have so many cultural and problems. You see, the way that the Europeans seeing how the patient was going to be after the operation, perhaps is different culturally from us here in South America. If you ask the relatives of the patient whether or not surgery is going to be done, there was the possibility of the patient become vegetative. They say, no, carry on, do the operation, do the best. So perhaps it's a different cultural. So that's why never there will be any equipoise. I think that I had the invitation to participate on the rescue ICP, also on the stitch by our friend David Mendelow. And there will be never an equipoise, because if I go to the patient and say, I don't know whether this is the best or that, and the patient, the relative will say, if it was your family, what would you do? That's a common question that we do here. So, and I agree that also, I only have the opportunity to take the patient and to have the best medical treatment possible if I do a surgery. I have no beds. My beds in the ICU. I have a patient who comes from the OR. So if I keep the patient in the trauma servicing, they don't have the best treatment that they could have in the ICU. So I only have that patient in the ICU if I take the patient to the OR. That's the straight question. And about the cystanotomy, I have 3 or 4 cases that I try to be there, go there, and I could not open up. I could not do the surgery. It was too much tight, the brain, that I stopped trying to do it. Thank you very much.
Professor Amar, you may ask your question.
Thank you very much, Heldo, for this very wonderful presentation. And actually, you raised up many questions, and it is a very nice result. I'm looking forward to see it. The question I have is also, we have a lot of experience with this. Do you have age issue in this patient, which you can say in the outcome? Does the age, especially pediatric patient, if you compare with adult or old patient? Because you have, I think there is, I would like to hear your opinion first, because I think that is age plays a role in it, especially pediatric.
Well, yeah, well, by protocol, we don't operate on patients older than 65. But we've been trying to study the results of patients over. I don't want to be a bias, but I'm over 65. But the results of patients older than 65, they don't seem to be much different from those. I mean, older than 65, I've been between 65 and 70. So we did a very few small study about this patient. I was working on these numbers, comparing 65 to 70 and 66 to 65, and the results were more or less the same. So, but our protocol is about 65, older than 65, we try not to do the operation.
Okay, did you do some pediatric patients to compare?
I'm sorry?
Pediatric patients, children.
Oh, yeah, yes, we have
How is that?
yes, wow. I think that some of the pediatric patients are those ones who respond very much better after the surgery. I think that the pediatric patients, I know that there are some papers in the literature, so but as you know, the figures are not very big. We see 10 patients here, 15 patients there, no more than that. So I think that below 20, we have at least 10% of the 350, and the results they go to the best part of this curve. I do push the residents and the young neurosurgeons to pay attention to this issue. Thank you very much. Very good point to raise. Yes.
Good to see you all, Hildo, Franco,
Hi.
and Liu. Good to see you, Professor Kato also. And it's great to hear to these talks. First of all, I would agree with Hildo in many things. Number one is in hinge craniotomy, we used to do that in India. We used to make two small holes in the medial aspect and then tie it with a piece of proline. That is what our hinge craniotomy was. And this was done in Vellore a few times. This is done only when the brain is really lax and then there is subdural. When there is bad swelling, if you try for hinge craniotomy without going into the base and opening cisterns, it's a recipe for disaster. So the hinge craniotomy, in our experience, has very limited role, and rightly, as Hildo had said. Now, second thing, early versus late. I think the most important thing is whether the BP has been kept up. In our experience, we have done late and early. We do cystonostomies, of course. And in our series, what we understood as the greatest factor is whether the BP, that means the MAP, that means the CPP has been kept up or not. If the CPP has not been kept up, and if there is an infarct, decompressive will not save him. Cystonostomy will not save him. Nothing will save this patient. Okay, so it is going to be a bad scene. But this is usually seen in cases of polytrauma or any other cases where there has been profound blood loss, or sometimes we also see in spinal cord injuries because of the primary shock, there is the third space loss, and this can also produce profound BP being down for some time, profound BP loss, and that can hypotension, that can produce decreased bad results. Now, other than that, we must also know about a few things about GCS. This is something which you are publishing. Very interesting, because Motor 6, obviously, nobody has an interest. M5 is a very good score to take these patients out. If we wait for medical management to fail, then we are doing injustice. M5 to M4 is a massive shift. What happens really is that when the patient, before the patient goes into M4, there is a ipsilateral pupillary dilatation because the uncus is starting to herniate. The uncus herniates, touches the third nerve, the ipsilateral pupils, constricts first, Hutchinson's pupil. And then after that, the uncus herniates. When the uncus herniates, the ipsilateral pupil dilates. And then what happens is the parahippocampal gyrus starts to herniate. And this is the time generally when M5 to M4 happens. And then M4 to M3 to M2 is a rapid shift. So if you notice, the patient's pupils dilate, and then suddenly patient's GCS and general condition goes down. And so waiting for the medical management in case of a surgical patient, especially in our setting, is a pure injustice. So early craniectomy obviously has better results. Early any surgery would have better results. Now about Hildo's comments about not being able to do the cystostomy. I understand if you are doing the same craniectomy flap as decompressive, it's almost impossible to get into this. I mean, I know Hildo is a vascular surgeon. So the only thing to treat this would be remove a lot of basal bone. You know, one of the things I would like to put into everybody's notice is that the Brazilian Neurosurgical Society has a magazine, and on the cover of it, once there was this article about cystostomies. Fantastic work being done in Brazil. So I believe it is Professor Jesus and Aline. They are doing a fantastic job. So it is just that there is a difference in techniques. It's just that it's a difference of perspectives. It will change for sure. It is if we try one technique akin to the other, meaning just extend one technique, decompressive, into cystostomy, it definitely wouldn't work. It wouldn't work for him. It wouldn't work for me. So it is just about removing at least 30 ml of bone at the base and getting right into the base. So we have noticed that except when there is a malignant edema, which means infarction, which means M2 and M1, and there is severe infarction, BP is not kept up. Except in these cases, we have now a combined series over 2,000 cases. We haven't found any exceptional difficulties. Yes, of course, there has been cases when my junior consultants have got into trouble, but there has not been. And now a lot of guys in India are doing it. A lot of guys all over South America. I mean, I was just in Mexico last month. We had presentations of cystostomy done by very junior people. So Hildo is an exceptional surgeon. I know that. So it is not that, it is just that it's extending that technique, decompressive technique into cystostomy will not work. That is all. It's just have to be treated like an aneurysm.
Thank you very much, your kind words, my good friend. I'm going to rethink and I try to persuade the residents, and we are going to go over this issue again. You deserve another try. Thank you for your beautiful work that you've been doing for the patient around the world. Thank you. Thank you.
Thank you, Hildo. Thank you. Thank you very much.
Professor Goel, you have...
Hi, Arthur. Good to see you.
Dr. Hildo, and it is my great pleasure, big honor to see you and to see you talking about a very controversial subject, decompressive craniectomies. I don't know much about. I have never actually done decompressive craniectomies. I am not sure whether decompressive craniectomies, I don't want to talk too much because I must tell you I don't know much about decompressive craniectomies because I don't do decompressive craniectomies. But in front of me, there are big experts of decompressive craniectomies. Dr. Hildo is there, Sir Franco is there, and it is my pleasure to hear them, to learn from them, and see how I can now use this kind of procedures in my surgical practice. Hildo, nice to see you, my friend.
Nice to see you, my friend.
Thank you, Professor Goel. Professor Kato, you have any comment, Professor?
So thank you very much for a nice presentation, and also the Franco. Thank you very much for the good chair. And I'm so happy to see and hear Dr. Akcharyan, your guidance of the cystostomy. Thank you very much. And even the two Goels, maybe in the train, I think. Are you traveling now?
Yeah, yes.
Okay.
I'm going back to traveling.
Thanks so much anyway.
Although I had COVID again 15 days ago.
Okay.
Still have some coffee.
Thank you very much. So maybe still I'm very wondering because the very severe head injury. So what is the best breakthrough to overcome the recovery of the brain, except for the decompressive craniotomy. So I think we have the many issues to be solved in the severe
I lost your last phrase.
So do you have any great idea? So besides the complex craniotomy, the breakthrough, the overcome the severe head injury in the future?
I think that what we have done is almost the maximum, because the capacity of the brain to overcome the injury is limited. So no matter what we do, perhaps we need to, if you have a very severe injury, what we need is to avoid or try to decrease the amount of injuries, try to decrease to penalize people who drink and drive, to penalize people who carry guns, and trying to decrease the aggressivity of the society, because otherwise I think that we are going to reach the peak of the technology, even having measuring the oxygen content of the brain, measuring the SgO2, measure the temperature of the brain. If you put everything together, there will be a limit. From then, you cannot decrease and lower the mortality and morbidity. But I mean, if you decide to do at least a DC, you do early. That's because time is brain.
Right.
Yeah, thanks so much.
Yeah, well, if I can make a comment.
Yes, please.
Yeah,
Thank
final
you.
comment.
Final comment, please.
Yeah, what we learn in this lesson, and we learn in the last years, is we have been too dogmatic. There is no treatment that can work everywhere and for every country and for every place. We need, as many colleagues have done already in oncology, for instance, to personalize treatments, using the resources that we have in the best way, not trying to copy what other ones have shown to be effective in a country with 10,000 kilometers. I give you an example of what I'm saying. If you look at the data of the intensive care management in COVID, the European study published 2,500 patients with pneumonia being admitted to ICU found that the first determinant of outcome is not the age, is not the extension of the pneumonia, is not comorbidities where you are. This is the first determinants of outcome. So we have to realize that something which is feasible in Italy cannot be used in Vietnam and vice versa. So the vision of a global approach to neurosurgery in trauma is even more pronounced. We have to work together. As Hildo has shown, we have to work together and find a way to adapt whatever we found in the West to other countries. This is what we have learned in the last years. So, Hildo, thanks again. Thanks, Iper, Ahmed, Yoko, to all the comments, and I give you the word.
Thank you so much. Thank you.
Any comment from you, Professor Tomasella?
I myectomy, there are some important variables. The time window, and I congratulate Hildo for stressing this point. The time window, the variables of a randomized study, as Franco Cervadei said, with different countries and probably different techniques, and so this is very important, and also different follow-ups. So I think it's a very exciting technique to face the severe brain injury. Anyway, as Professor Azevedo said, probably we reached the maximum of our efforts for this condition. And this the intriguing aspect of this is that with the compressive cardiectomy, probably we can save life, but we cannot save the quality of life of this patient. It's a very important aspect.
Thank you, Professor. Now it's time for us to move on to the last speaker. May I invite Professor Amar to call upon our last speaker, Professor Tomasella. Professor Amar is a professor and consultant neurosurgeon from King Fahd University Hospital, Saudi Arabia. He's involved in a very busy neurosurgical practice, operated more than 6,000 neurosurgical patients with special interest in pediatrics, have published more than 100 manuscripts in the international journal and presented over beyond 500 talks in national and international scientific meetings. Professor Amar, please.
Thank you very much. It is actually an honor and a pleasure that is to participate in this special event, the third annual memory for Professor Kanno. But it is also a great honor and a pleasure to introduce my friend, my very dear friend, Francesco Tomasello. Professor Francesco Tomasello is a professor of neurosurgery in Humanitarian Hospital in the south of Italy, in Sicily. And he is one of the most distinguished neurosurgeons not only in Europe, but in the whole world. He really honorary president of WFMS, but he also participated in many societies and in many committees and received many honors. Professor Tomasello is also an inventor. He is the chairman of Italian technology or instrumentation. He's the vice chairman of International Society of Neurosurgical Technology and instrument development. He's a great neurosurgeon and he's a wise man, and at the same time, he's a great educator. It's a pleasure to introduce you, Dr. Tomasello, and to learn from what you are going to say.
Thank you, my dear Ahmed. I thank you so much for these touching words. I do not deserve, but you are a very good friend. We worked together, and you know my interest in neurosurgery, and I know your passion for neurosurgery. So this is very important. I try to share my screen. So I thank you, Ahmed, for this very kind introduction, and I thank you so much, Yoko Kato, for this kind invitation, which is a great honor for me and a great privilege in memory of Professor Kanno. This is a great event today because we are honoring a giant of mentoring and outstanding neurosurgeon as Professor Kanno, and a great man. So this our idea today also for whom was unable to meet him before, and I really am very grateful to Yoko Kato because for me it's very important to give some short ideas about the skull-based surgery. We know exactly that we need to build a global neurosurgery in order to serve millions of people who face unmet needs in neurosurgery. So if we want to build a global neurosurgery, we have to understand different skills different resources and cultures. Why I chosen this title for this very important Tetsuo Kanno memorial event? Because I am completely aware of his efforts in achieving an outstanding surgical skill, in educating neurosurgeons from the developing world, as was reminded during these lectures, and in driving Asian and global neurosurgery, and caring quality of life, which is very important, of patients and last but not least of their families. And we are indebted with Professor Kato, publishing in Asian Journal of Neurosurgery, the real life of Professor Kanno. And there is in this paper a sentence of Professor Russell Andrews, it's likely, he says, that Professor Kanno has done more than any other neurosurgeon to champion the education of neurosurgeons from the developing world. So I decided to face this aspect of global neurosurgery with reference to skull-based surgery. So also we are indebted to Yoko Kato because she reminded to us what was the philosophy of Professor Kanno during his long career. He said, in my 50s, I started to bring excellence in treatment of my patient and surgical outcomes. And he mentioned in total tumor removal in the heroic skull-based surgeries. In my 60s, I focused more on the happiness of patients and their families. This is an important change that most of us are living in our experience, just to care about the quality of life of our patients. So I would like to mention a sentence of Alexis Carrel, surgeon, Nobel Prize: quality of life is more important than life itself. And recent papers with reference to skull-based surgery, in selection of right treatment for a specific patient, the surgeon should consider not only the best approach to remove a tumor, but also the impact of treatment on the quality of life of the patient. And more recently, quality of life measures are increasingly recognized as critical component of surgical outcome, always related to the skull-based surgery, which is, as we know, a challenging surgery for the quality of life, especially. I had a recent meeting with Vinko Dolan, who was the pioneer in this cavernous sinus surgery, but he expressed some criticism about, not about the technique, not about what we learned from his work or from a neuroanatomy of cavernous sinus, but about the quality of life of patients. So we know that we have several approaches to achieve skull-based tumor removal. And I mentioned only the main approach, anterolateral, and in red are my favorites: pteryginal and mini-pteryginal, subfrontal uni or bilateral, front orbital zygomatic with adjunctive osteotomies, supraorbital, endoscopic, endonasal for selected cases, and posterior approach, the classical anterior petrosal approach of Cavase, posterior petrosal and variants, pre-sigmoid, but there was a very important increase of preference for retrosigmoid approach and the suprameatal tubercle approach as the the classical approach to the cerebellopontine angle, for example. As we know, we have at present new tools for contemporary skull-based surgery and new techniques, intraoperative monitoring, microscopic, endoscopic, technological advances, or extended cranial exposure, as I told before, or minimal invasive approaches, minimizing brain retraction, reconstructing new reconstructive techniques to avoid the CSF leaks, and with the advent of radiosurgery, debate about radical removal versus conservative attitude. I am in favor of radical removal, as most of us. Anyway, we have to face now the contribution of radiosurgery and quality of life patient-oriented scales. So with this new deal in the skull-based surgery, we know the approaches to transcranial, as I told before, and transnasal with the endoscope. But with the aid of two important tools, which remain important also today, the operating microscope and the endoscope. The evolution of anterolateral approach from the Dandy frontotemporal to the asalgipterinal and with the adjunctive osteotomies to the Pernesky supraorbital and the minipterinal of Spätzle. We saw that there was a minimalization of the approach, not of the access, of course. Front orbital zygomatic was used, is used also today, but in very selected cases. For tuberculum cell meningiomas, for example, the pterinal approach is absolutely a very useful approach, and as you see also with the large tumors extending laterally from the cellar region. And we see this important small area with vessels, nerves, and also pituitary stalk. And you see that this is the classical view from the anatomical point of view, but also from the surgical point of view. I have no time to show, but this is the classical approach by pterinal, and the bulking of tumor between the optic in the window, optic carotid window, and at the end we see that we can check very carefully both optic nerves and pituitary stalk. So the pterinal approach seems very useful for these lesions. But this important thing in this is the preservation of optic nerve microvasculature. This is the ICG of this case, and you see that the preservation, I think, is very important, more than the approach, only the approach, because the preservation of microvasculature gives us a better functional outcome for these patients. And from the other side, we can see the same region from below with the endoscope, of course. And you see also a case very in the middle, which can be suitable for an endoscopic approach. I can show you, but you see that the removal of a small meningioma from the cellar area and the view from this side, from below. and the postoperative control. The supraorbital approach is another approach which was popularized by Pernesky and can be performed with some variants, but the cosmetic results is really good at the end. Also for large tumors as sphenocarditis meningiomas. This is an important issue with reference to what I said before about the cavernous sinus. These are tumors growing until the lateral wall of cavernous sinus, but sometimes invading the cavernous sinus, have the different for example, Al-Mefti calls this tumor clinodal type 2, and Aziz sphenocarditis, as I published in 2003. Petrinal approach is suitable also for this tumor because you can have a large space debulking the tumor, and you can operate this tumor only if you perform an early and wide Sylvian fissure opening. And at the end, you can have a view of the carotid artery and this branch, the third cranial nerve, and the optic nerve, which in this case is distorted, dislocated by the tumor. You see here, and you see the growth of tumor around the cavernous sinus, but at the end we have a small remnant along this the wall of the cavernous sinus. What was my experience with these tumors? The experience is that in this case you can peel the lateral wall of the cavernous sinus, as we see, but I don't I don't enter the cavernous sinus. And this is absolutely possible today because we have the possibility to complete the treatment with remnant or with a case of regrowth of a tumor by radiosurgery, as you see here. For a posterior approach, the Cavasi approach, and you know the petrosal approach, the posterior petrosal approach with the retrolabyrinthine, translabyrinthine, transcochlear, but there is a great interest now in retrosigmoid. Retrosigmoid is considered not useful for every lesion, but mostly useful for many lesions in the area of the cerebellopontine angle or in the petrous bone. And you see this petrosal approach with the presigmoid approach, as you see here. But for example, in this case, I used a retrolabyrinthine approach, as you see here in the postoperative control, and I was reflecting on this afterwards. It was unuseful to do this. And in similar cases, you see here, a retrosigmoid approach was useful to remove this tumor without injuring the labyrinthine structures. So retrosigmoid approach is so popular because it has some advantages, as safe, is hearing preservation, early drainage of CSF, and early visualization of lower cranial nerves. But has also some disadvantages as to no early control of the tumor feeding vessels, and this is really important. There are some variants popularized by Majid Sami and also by Albert Rodin, the suprameatal extension of the approach to control the rostral portion of the angle, and also the transtentorial removal of tumor. So you see here for petrosal meningiomas, this is the possibility to check the hidden corners by endoscope. But if you look at the microscopic view, you see that we can do this, and I say this for the problems of global neurosurgery. We can do this by macrosurgical technique, also if we have not available an endoscope for this. This is a rostral meningioma of petrous bone, and you see that it's possible to remove this with intraoperative monitoring and with endoscopy. So this is, I have no time just to show you all this dissection of the tumor from the fifth nerve and from the petrous, superior petrosal vein. And you see also retrosigmoid approach can be absolutely utilized for a petrous apex meningioma, as you see here in pre and post-op. And you see in coronal section. Why I say this, that you can use a retrosigmoid? Because retrosigmoid is universally known, and probably may be performed in several parts of the world with more familiarity. So this is very important. Of course, Cavase was able to suggest a very exciting route, which is the classical Cavase route to petrous apex, and you see moving between different important functional structures as SPN and the arcuate eminence. And you see here the triangle that you can use to approach the posterior fossa through the petrous apex, and this is a post-operative control of this approach. But the main problem is that we need, of course, to perform neurosurgery, we need light and magnification. And I want to give a tribute to a great painter, Caravaggio, who is considered the painter of light and shadow. We need light. And for this, we used, and we are using since a long time, operating microscope, but there are new tools as digital, new definition, high definition, better depth of field, ergonomic advanced learning curve. But I would like to mention this paper of the group of Tatajiba, concluding that the operating microscope is the gold standard visualization tool in neurosurgery because of its illumination, light, stereoscopy, and magnification. The great advantage of other tools is the ergonomic help for the surgeon. So we know that the endoscope is very important. I performed several procedures with endoscope assisted microsurgery. We can see very clearly very important structures as and the rostral portion of the cerebellum pontine angle, superior petrosal vein, and the superior cerebellar artery. But also by microscope. This is at the end of a procedure for a petrosal meningioma in the same area, and you can see that with the microscope we can see the superior petrosal vein, the fifth cranial nerve, and the seventh, eighth cranial nerve, and the arteries. So I understand that if we need to raise the global neurosurgery, we have to use microscopes. It's true that in many parts of the world they have no microscope, but the microscope will remain an important tool for surgery, and for surgery of skull base, of course. And you see, but endoscope changed our perspective, as we can see with the basilar artery. Anyway, we have to think about essential surgery without surgical narcissism. This is my idea. And so, of course, all know that there are these new tools, the surgeon controlled robotics, the exoscope, which is ergonomic, of course, the other type of video microscope. And I would like to mention this important Japanese project of very advanced operating theater, the so-called smart cyber operating theater, with this an integration of new devices into AI technology environment. But this is the prototype for the global neurosurgery. I don't think so. I think that the global neurosurgery has to face problems with medical equipment, human resources, environment, material resources, and as Professor Kanno taught to us, educational resources, capacity to train the workforce. And this I am glad to mention this paper of the World Federation with Franco Servadei included and leader on this paper, stressing the fact that there is a lack of neurosurgeons in Africa, more than 8,000, in Southeast Asiatic region, more than 11,000. So this is these are figures which we need to face for the near future. But also, I would like to tell you that the devices market was growing in all continents, but as you see, was growing in North America, in Europe, but also will be growing in Asia Pacific, really less in the rest of the world, is this yellow histogram. So there was a paper which is very impressive, published in Journal Neurosurgery, on the use of smartphone to assist in neuroendoscopy in low resource settings. This is a paper which prompts us to reflect and to think about the fact that we have to face this problem for millions of people. And the neurosurgery is not only for the more developed countries, is for all the world. And just to remind that we have now societies with multi-ethnic presence, we need to face cultural diversity. And probably this was one of the aspects that Professor Kanno considered in the last part of his life, more in the last part of his life, but probably all his life. Cultural factors strongly influence patient reaction to serious illness, as some skull-based tumors. In contrast to the emphasis of truth-telling in the United States, it is not uncommon for healthcare professionals outside the United States to conceal serious diagnoses from patients because the disclosure of serious illness may be viewed as disrespectful, impolite, or even harmful to the patient, inducing anxiety and depression. Many ethnic groups prefer not to be directly informed of a life-threatening diagnosis. And the perception in the low middle-income countries for patients toward neurosurgery are strongly influenced by their socioeconomic status, culture, and religion. They appreciate communication. Meaningful participation is only possible if the neurosurgeons establish a relationship of trust with their patients. But in some African countries, in Eastern European countries, the preferred doctor-patient relationship is the paternalistic model. This was published with a survey very recent in Neurology India. And cultural diversity in decision making, especially when you talk about a serious skull-based tumor with possible great risk. And with regard to decision making, the emphasis of the United States on patient autonomy may contrast with other models. Among Asian culture, family-based medical decisions are a function of filial piety. Illness is considered a family event rather than an individual occurrence. When considering therapeutic option, neurosurgeons should consider that members of many cultural groups prefer that family members, rather than patients, make treatment decisions. This is, of course, should be considered when we speak with people coming from other countries. So finally, which are the lessons we learn at the skull-based surgery? Knowledge of neuroanatomy is fundamental, and we saw that Professor Kanno promoted several courses of neuroanatomy on hands-on dissections and so on. Removal of bone is justified just to minimize brain retraction and was advocated for extended approach. Investigation on new approaches is an exciting challenge, but violation of critical areas only if this is possible, avoiding invalidating deficits. Radical removal of tumor is our main goal. We know this very well. But awareness of personal limits of surgeons is, however, important. And one important lesson to keep in mind is that we don't pursue surgical narcissism, but we pursue happiness of our patients and their families, as Professor Kanno said. This is an ethical issue. Technology and innovation are fascinating, but their contribution to improvement of patient outcome sometimes needs to be validated. Probably we can do neurosurgery also with more limited resources. Education, resource, and problems of cultural diversity in low middle-income countries are to be faced. I know and I understand, as we all understand, that the daring approaches to skull base are exciting. But as we saw from many masters of neurosurgery. Simple is often best. So we can reach our goals in surgery also with simple procedure. Thank you so much for your attention.
Thank you very much, Francesco, for this wonderful presentation. It's full of lessons, knowledge, points, philosophy, ethics, global view. It's wonderful presentation. Thank you very much. Is any questions?
Did I say something, Gama?
Yes, please.
Well, my friend, Professor Tomazello, honorary president of the WFNS, I could not refrain of congratulate you for your excellent, not only didactically showing the several approach, but showing absolutely perfect technique, but also in the end, talking about global neurosurgery and also some philosophical ideas that run our profession and our specialty. I usually say to the residents, to the young neurosurgeons, that you operate on patients, not on CT and MRI. So then, what you did emphasize, the quality of life is very much better than a full and complete removal of a meningioma on the MRI. So 25 years ago, I was ashamed of living behind a bit of tumor meningioma around the brainstem for a clival-meningioma. But would you ask the patient to whether he would like to have that small piece left behind or to come out with a brainstem infarction? Or what is the necessity of for a non-functioning pituitary adenoma to go into the cavernous sinus? What the necessity? Would you compress the optic chiasm? It's okay. And if the patient, if the tumor grows back, you go, you do radial surgery. So it's not because I'm old now, but not become coward. I've done all sorts of these approaches, and the resident should know it, but should know that they do it for the sake of the patient, not for the sake of your egos. So then I used to have the to quote my former professor in Oxford, do the KISS technique. What's KISS technique, boss? To keep it simple and safe. Thank you, my good friend, Don Franco Tomacello. Good to see you.
Thank you, Hildo, for this comment. I remember, I can't forget, an European lecture of a great friend, Fabian Izamat. Fabian Izamat, the title of his European lecture was An Act of Contrition, because I was younger and probably I was unable to fully understand the meaning of his message. But now I think that many of us think about the failures more than the successful operation. And you are right when you say, what is the necessity to do this? Just to gratify your bride or to gratify the patient. This is, and I think that the thought of Professor Kanno, which was reported by Yoko Kato, is just addressing this aspect of our life as neurosurgeons. We need to be more careful about the quality of life, more than our pride in achieving a radical removal at every cost.
Ahmad, can I make a small
please.
comment?
Absolutely.
Francisco, that was fantastic journey of yours, long duration, very acknowledged. You are one of the very prime neurosurgeons of the world. No question, you have taught the whole generation of neurosurgeons how to do skull-based surgery, how to make it safe, and you have taken the message throughout the world. There's no question about that. And you, over the period, what you have said is that you have compromise on radicality of resection for the safety of patients. These are very important messages that a person of your level has to give. The other thing that is very important that you have said is about doing neurosurgery in lower income and small, poorer countries. So my feeling is, you know what, with now the information by web that every neurosurgeon in the world can have most modern information about neurosurgery. And what Professor Kanno has done is in his career, and also Professor Yoko Kato, that they have taken neurosurgery to the remotest corner of the world. And when I see myself, and I have given this kind of lectures several times, that we can do neurosurgery in a poorer environment. Best neurosurgery of the world can be done in India, for that matter. What we need is, we need a very good microscope. We may not need a very high-end sophisticated microscope. Even if we have a reasonable microscope, reasonable drill and reasonable bipolar, and maybe an endoscope, we can do everything. And we have no excuses. We cannot say today that I am a poor country, so I cannot do, I'm sorry, I don't have equipment, I cannot do, I do not have a robot, I cannot do. These kind of excuses are absolutely useless kind of excuses, as you have said. We can do neurosurgery. What, you know, the power of like a poor country like India, my power is so many patients. We have got so much huge volume of patients that we can operate daily, multiple cases. So we should use our power, and we should use our power of our volumes. We should use our power of number of complex cases, number of very difficult cases, operating number of cases in a day. So this power makes us, you know, it is not income. I think we should not call it income. We should call it the volume now. And we should label the country's power of neurosurgery not by income, but by the volume. And I think this power can be used very effectively in countries which are relatively like Africa. There are so many fantastic number of cases. And of course, there is no question what cases we have in our country. There can be no parallel to that kind of. So I think this question that talking about low resources and low income should not be discussed anymore, Francisco. I think those are history now. Neurosurgery should be looked upon as a parallel. The message which Professor Kanno gave, and he to the remotest part, use microscope, and he has taught. You see, he has given microscope, he has donated microscope to various less fortunate countries. And now I think there is no excuse. We cannot say I cannot do good neurosurgery. So in short, what you have said is that we should do good neurosurgery. We should become good neurosurgeons. We should think about the patient. We should think about performance, and don't give excuses anymore. The era of giving excuses is completely gone. And that is always I have talked about for 25 years, that we in India can do the topmost neurosurgery in the world. Don't make excuses that we are a poor country, we cannot do. So this, I think, is a very important message, Francisco. And I think this is the thing which Professor Kanno and Professor Kato has taught us and taken this into deeper parts of the world. Thank you very much for this wonderful, wonderful lecture.
Thank you, Atul, for this very, very kind words for me. But I have to tell you that, for example, I was impressed by your papers and speech on the treatment of craniocervical malformation and the syringomyelia, because you changed our view with a more simple procedure for this, probably more simple than go through the skull base, and through other pathways. So the stabilization of the cranial vertebral I think it's a great idea, and I want to have this opportunity to congratulate you to change our way to look at this particular disease. Thank you so much, Atul.
Thank you, Francisco, for those wonderful compliments. And Ahmad,
Yes,
Professor Amar.
yes, my friend. I really enjoyed very much everything in today. Today is a great day. I believe Dr. Kanno is very happy now. He's looking at us. You know, it is what is remarkable today, and which is not planned, but it came like that. We are not talking about excellent technique, our best outcome of a patient, but of a result of a, but we are talking about ethics, philosophy, mission for better life for our patient, which is the first step to it, to get better education and better training. And the first step to build this, to have a humble personality and in the same time dedicated personality. I think all the talks going around this, that is, and that is exactly, this is the personality of Professor Kanno, and this is the personality of Professor Yoko Kato, and also the personality of Dr. Hildo and Francesco, and my dear friend Atul Goel, who is a philosopher of neuroscience. He knows I love him very much. And of course, Dr. Selvi Kono. It is a wonderful day, truly wonderful day, educational day, and I am so grateful for the invitation to be part of this wonderful day, which I will never forget it. Thank you very much, Captain.
Thank you, Ahmed. I was thinking about the great contributions you gave us with reference to the ethics in neurosurgery. You really gave us a great.
Thank you very much.
Prof. Selva, any comment from you, Prof?
A wonderful presentation from everyone today. And I only wish Professor Kanno has brought us all together today. You know, that's most important. And it was his wish that we all are here today and then talk about him. And I think we have discussed quite extensively on so many important matters for the young neurosurgeons. I think more the younger neurosurgeons have to participate, because that's the ultimatum. See, whatever we have been talking today, it has to reach the young neurosurgeon. That's the basic thing, you know. And I think Dr. Kato has already taken such a great initiative of bringing these lectures to the young neurosurgeon. I think that's very important. Thank you.
Professor Suwade, any comment from you, Professor?
Oh, no, it's okay. We had a very nice lecture from Professor Tomasello. Nice comments. I can't do anything else than agree and say a great hello to all of you. And I really wish to see us in person as soon as possible. We now can start traveling, and I think it will be a pleasure for us to see each other.
Thank you to all professors. For your information, this live session also are translated into the Chinese language by professor in China and broadcast to the Chinese audiences also. And before we end the session, may I call upon Professor Kato for her closing remarks.
So I thank you very much. Sorry. I thank you very much, the Tomasello, because you raised up the two very important things. One is quality of life of the patient, and another one is minimally invasive, even from such a great skull-based neurosurgeon. So for the YNS, always skull-based the surgery equal maximum invasive, something like that. But I think the day by day we had a very nice equipment and instrument. So maybe the endoscope, pure endoscope or pure exoscope. So maybe I think in the future the robotics. So I think the more less invasive for the patient treatment will be coming up soon. My feeling is maybe of course in Europe already the clipping surgery has gone, but still in Japan is about 40-60%. I think those time changing is very, very important. And also Ahmad, thank you very much for your very philosophical ethics things. I think the Professor Kanno had a great day in heaven, I think. So always Professor Kanno was surrounded the nice doctors. So maybe I think we can follow his philosophy and also the step in the future. We had very great the teachers, the talk today. So happy. Thank you very much.
Welcome.
Will you?
Welcome. Thank you so much.
Thank you. Thank you very much.
Thank you, Yoko. All the best to you. Happy New Year to all of you.
You too.
Thank you very
Thank
much,
you.
everyone.
Bye, everyone. Bye, everyone.
Bye. Bye.
Yep.
Thank you so much.
Right.
See you next year.